a structure with a tiny opening, the channels. Okay, so what is BPH? BPH is actually a proliferation of both the stroma and as well as the epithelium of the gland. Okay, so usually the BPH tissue arise in the tissues around the urine passage, not the periphery. Around the urine passage, that explains why when the prostate is enlarged in a setting of BPH, the patient would have problem with urination. All right, okay. So actually, there are two components of the bladder outlet obstruction. So one part is the static component, which is the size of the prostate. The second part is the dynamic component, in which there's increased the smooth muscle tone around the prostate urethra, and both of which is the reason why patient with enlarged prostate, there is a risk of problem urination, therefore urine retention. Okay. However, the prostate size is actually not a very strong determinant of how someone could pass urine nicely. Someone with a small prostate, slightly large, but could still have lots of problems with urination. Some men with a very big prostate, 60, 80 cc, yet they could still pass urine quite nicely. Therefore, the size alone is not the only reason. We have to look at lots of things, okay? Very dynamic down there. It's a balance of both the function of the bladder and also the how constrictive is the prostate, okay? As a matter of fact, what we see among men, the problem with urination is also quite common among the females. So therefore, especially among the elderly population, therefore, someone who has problem with urination is much more than what I could see. It could be because of age changes associated, causing this problem with urination. So how common is BPH? Right, so it is fundamentally more common with aging. So 50 or so, 50% of men will get big prostate, and 80 or so, 80% will get a big prostate, especially if there's a family history of a BPH. Okay. So what we could see when someone is relatively old and then have what a problem when it comes to their urination issue? Quite a lot, because of the fibrosis. They have a reduced bladder capacity, they can't hold much urine, but yet they are not able to compress nicely, so causing urine retention. And also they have a decreased urine flow. That can be a result of the bladder not able to compress, or because obstruction along urine tract. All right. And also because I think long-term irritation or long-term inflammation, the bladder would end up having like a overactive, and that's why I call it the judicial overactivity. So patients like this, they have like the problem of urgency. Okay, classically described urgency. Of course, different patients describe in different way. Okay, all they could have an impact contraction of the judicial. They just cannot empty the bladder. Of course, part of the organ, they also have problem with the sexual performance. So lower urethral symptom, LUTS. What are the symptoms? So largely you can divide them into either soil symptoms or the voiding symptoms. The void symptoms are the one which is, the examples: weak stream, hesitancy, prolonged hold or prolonged void, straining, dribbling, so on and so forth. In contrast, soil symptoms, they are frequency, urgency, nocturia, and incontinence. Of course, look at this, it seems to be difficult to remember what are they. As long as you can remember the funny symptoms, then you know what are the solid symptoms. The funny symptoms are frequency, urgency, nocturia, and incontinence. Clearly, these are symptoms which are not fun at all, because these are the reason why the patient come and see a doctor. They do not mind the urine flow being slow, but find hard if they can't hold a urine. They find hard if they have to pass urine very frequently. They find hard if you have to wake up at night to pass urine repeatedly. Okay. So what are the causes of LUTS? Quite a lot. Okay. It can be local factors or systemic factors. The local one, for example, can be because of big prostate. a stone, or because of inflammation, or because of a tumor, or in a systemic manner, it can be because of Parkinson's disease, stroke, diabetes, right, or because of medications, all right. So when we have someone having problem with passing urine, of course, we could ask them how bad is the flow, how much their life is affected. But to standardize the symptoms, we can actually use the IPSS scoring, right, to see how bad is the patient is affected by the LUTS. So in general, if the score is 0 to 7, is considered as mild, 8 to 19 is moderate, and anyone who is above that is considered to be severe. Well, I have to say that this is something which is really good because it has been translated to multiple languages, very suitable for our local setting. Bahasa Malaysia, English, Chinese. I'm not too, I can't remember whether it's the same time. Yeah, but in general, I don't really use it because it takes a lot of time, even for me, to actually read the questions and understand what they ask and then the answer. Of course, now I understand a lot better. For patients who only see once in a while, it do take them quite a bit of effort. So probably something that patient can fill out when they're waiting to see you or they're waiting to do any tests. Okay, useful, but just take a bit of effort and time. So LUTS, is it always BPH? It is no. Because why? One of the things that we don't usually mention that much is actually prostatitis. You had, just like what I mentioned before, prostate looks like a solid organ, but actually internally there are a lot of small ducts and also the ascina. So this is where the juice being excreted into the urine passage. Okay, so I think because of the structures, there could be accumulation of bacteria or chemicals causing the prostate to be inflamed. So as you know, when there's inflammation, there will be like enlargement, there will be tenderness, there will be pain, there will be redness. So because of this, the prostate is irritated, enlarged, and therefore being the gatekeeper of the bladder, patient commonly would experience problem with urine flow. So it can be at either extreme, hard to pass in because the door is being shut, or it just cause irritation to the bladder, making the patient constantly having the compelling urge to pass urine, okay, night and day. So what are symptoms of prostatitis? Well, actually they are overlapping, okay? So sometimes it's just not possible to know whether it's prostatitis, whether it's a BPH, stone, or whatever it is. It's confusing, okay? Yeah, non-specific. And also it can be like an overactive bladder. All right, so it can also be obstructive light, like a spectrum. And then although classically, when someone having prostatitis, the pain is described to be classically at the perineum, but not all patients describe pain. Some patients describe like soreness, a sense of pressure, right? And this sensation can actually radiate to lots of areas. For example, to the penis, to the testes, to both inner part of the thighs, to the lower abdomen, or even to the back. Okay, so as a matter of fact, it can sometimes look like a stone when the pain radiates to the back. Okay, it can be acute, happening within a span of days, or could be chronic, years, 10 years. Okay, and of course, we have to look at the patient's medical background also, because the background it can affect how we decide what the patient could be having. For example, some with diabetic. Then we look at the bacterial, the infected spectrum, maybe not exactly bacteria. All right. So do not forget the inflammatory component. So it's largely because inflammation causes problem. Okay. So what are the causes? We can divide into either inflammatory. So infective, it can be bacterial, it can be fungal, it can be tuberculosis or sexually transmitted disease. Who gets it? Men. Okay. Yeah. So very, very difficult to treat, I must say that. Of course, commonly we do get away with a good outcome, but there are some quite number of patients who they don't get the entire relief of symptoms, okay? Probably just recovering for just about 60 to 80%. All right, so yeah, the classification shows that there are actually a lot of way we kind of make classification. But I just make it very simple for everybody, just remember whether it's infective or inflammatory. Infective are those what I mentioned before. Well, inflammatory, it is a bit hard to identify because to see what is thing that's happening, what chemicals. Fundamentally, you just can't tell what could it be the agent. All right, so this is the triangle of what we are talking. Bermuda Triangle. What could it be? Prostatitis, BPH, or overactive bladder? It could be just BPH, but somehow with the problem in urine flow, the prostate got infected, patient ended up with BPH and prostatitis, twin one. Or someone, this is especially so elderly, but in a youngest patient, of course, 20 plus, 30 plus, unlikely BPH, so they may have a same presentation like a BPH. In that case, probably in most likely to be like a case of a prostatitis, okay? Yeah, so, but if someone who has a chronic prostatitis, whether that could be BPH, well, I think it's still hard to answer in this regard. Another thing is the OAB, overactive bladder. So another big spectrum on its own. I'm sure you have known very well about OAB, but just do a summary. OAB, largely you can say OAB can be a primary or secondary. Primary side is just don't find a reason. Of course, things that can cause irritation to the bladder, for example, bladder irritant, coffee and tea, alcohol, cigarettes, so on and so forth. This can cause over the bladder. But if it's secondary, then it can be second because of the prostate being inflamed or because of the bladder dysfunction causing an OAB. So that itself, I think because the treatment is quite in different spectrum, I just leave it at this right now. So we just focus on what we are looking at today, the prostate. Okay, so when we examine patient, what do we see? Well, of course, we examine abdomen to see, whether it's any papa bladder. That means that there's urine retention. Then we also perform the digital rectal examination. So when you do the digital rectal examination, what do we feel? Well, to look for enlargement, it is not so accurate. That one usually require an image studies. So the digital rectal examination largely for us to feel whether there's any tenderness. That means that prostatitis. Or is it a bulginess? That means they may have an abscess now. Or is it nodular? That means it may be a case of cancer of prostate. All right. Besides this, what else do we do? The simplest that we could do is a uroflowmetry. So it is a test in which a patient will drink water, and then when they feel the bladder it's just about full, not very full, then they pass urine into the machine, and that machine will register how great is the urine flow. All right. Okay, so this is basically how we ask the patient pass urine. Okay, so normally the graph would looks like this, the green one, like a big mountain. But when the patient having an obstructed flow, well, we cannot say whether obstructed. It could be because of poor bladder contraction or some obstruction. So you give a pattern of low flow rate with a prolonged urination duration. All right. Yeah, so besides this, what else could we do? Well, after patient pass urine, we measure the urine, the amount being voided, and also we do a scan to see how much bladder volume towards the end of urination, except to see the post-void residue. Okay? All right, so after this, what else do we do? Well, we can do simple things like renal profile to look at whether the kidneys are affected. We can go for the urine FME to look at many things. Look at the pH. If it's very much alkaline, 8 or 9 can be because of infection, whether because of microhematuria, whether any sugar, then maybe a case of diabetes, right? Because or whether is any nitrates, so on and so forth. And then, of course, we can also consider doing a test for PSA. Well, PSA itself is a big topic, so I'm sure you know what it is. I think for the moment, I just leave out this topic. And then the things they can do is the simple things is like transrectal ultrasound, which I found is something which is quite simple, all right, a bit uncomfortable, but give quite a bit of good information. Can measure quite accurate the size of prostate, all right, and also it allows us to see is there any intravesical protrusion of the prostate, and also it allows us to see whether is there any calcification inside the prostate, classical hallmark sign of a prostatitis when there's calcification. All right. Of course, I think you can do like a culture studies. Urine culture might give some results, but more so if I go for a prostate massage, then collecting the juice then it might be even more meaningful to look for any bacterial infection in the prostate. All right, so let's move on. Now we talk about how do we treat the prostate, the enlarged prostate. When we treat the prostate, of course, we look at things. We look at how we can relieve the symptoms, all right? How, and also want to understand the patient as patient, the age, the medical background, how much the life is infected. Of course, they also do not forget us about whether the patient feels sexually active, because this is fundamentally a very important question to decide how do we treat. All right, because if we understand medication does come with side effects, therefore when the symptom is not so bothersome, when the symptom only bother patient very slightly, you have a choice of not giving the treatment just yet, just monitor. We can only initiate the treatment when the patient really felt that their life is very much bothered by the urination. Okay, so before we move on, so what are the things that we expect to see? How do we decide the treatment for the prostate? Well, just remember that there's a lot of blood around the bladder neck and the prostate. Okay, they are not so much around the bladder body. Okay, so alpha receptors. So when we block alpha receptors, that means the alpha blocking, it allows the patient to have smooth muscle relaxation, acting on the dynamic component. So this allows the patient to have the ability to avoid urine better because of the reduced muscle tone around the urethra. Okay, so the benefit of alpha blockers, what are they? They work quite fast. It can be within a couple of days or within a couple of hours, but usually they tell patient about 3 to 4 weeks. And also using it alone could actually reduce the IPSS score quite a lot, about 4 to 6 points. Okay, and also we can use it to trial, as a trial for someone who already have failure to pass urine. Okay, this one I'll describe later on. However, it doesn't quite reduce the BPH progression. That means that ended up urine retention or stone formation, but it's just for the rapid relief of the urinary symptoms. Okay, so the thing is that the alpha blockers, they are not similar in terms of their urea selectivity. Quite a lot of choices out there. They are quite nice, quite good medications. It's just that they are quite different in terms of the performance, in terms of selecting the urine tract. So this study shows that among all the common alpha blockers, alpha seems to be the one having more selective towards the urine passage. So clearly it is very attractive because BPH commonly is more commonly seen among men with age. So therefore, if it's selective to the urine passage, it is more beneficial because it sort of gives us the confidence that it prevent the postural hypertension. Clearly important. Otherwise, patient with giddiness, it might just fall. So it looks like it's opposing quite hit a point. So, but what are the other side effects of alpha blockers? Quite a lot. Besides the hypertension and giddiness, there are also patients who might describe problem with the ejaculation. Okay, look at this table. Right, again, the common alpha blockers. One thing we find very interesting is that let's say the common like hypertension looks like they are quite similar in terms of their percentage of hypertension, but one is quite interesting is that problem with retrograde ejaculation. It seems like it is either zero for avulsion or just plainly not reported. Well, I think this is quite important, okay, for us to address, especially men who is still sexually active. They might be 50, 60 plus, but yet, as I'm sure you understand, sexual activity is fundamentally part of human being. So because of the alpha blockers causing their urine passage to be relaxed, so therefore the patient during sex, the sperm, it is going out, it just make a U-turn back into the bladder. Not harmful, but it can cause less joy in term during their activity. So it looks like when someone is still very much enjoying their sexual activity, so if we can provide them something that can eliminate these side effects, seems to be very much attractive for patients. Okay, yeah. So besides alpha blockers, what are the choices? So another group that is very useful is the group under the category called the 5-alpha reductase inhibitor. So there are two choices, finasteride or dutasteride. So it works by reduce the size of the prostate. Takes about 6 to 12 months to act, all right? But it doesn't reduce the size completely to just about quarter. But they're more effective for prostate, which is much bigger in size. For example, 40 cc and above. Okay, so not for all patients. So it's how it acts. Basically, it's just act hormonally, blocking the hormone action to reduce the prostate size over a long period of time. So again, what are the side effects? Because how it acts on the hormone, common problem is that patient will have problem with the sexual performance, namely problem with erections. Reassuringly, the side effects, they are actually reversible especially after the first year. Okay, but of course it might not completely recover. Okay, so therefore, when someone have an enlarged prostate, then we have to step up our treatment. So alpha blockers alone may be not enough, so we consider a combination treatment to look at the short-term relief and also a long-term relief of the urination. Okay, so different medication act on the different parts. So alpha blockers on the dynamic part, and then the 5-ARA is on the static part, the size. So this is basically the outline from the European guidelines. It's to make it very simple for to see. So when the urine flow isn't much bothersome, to leave it alone. But when the urine flow start to affect the patient's life, you can consider and the alpha blocker first. Okay, and then if the urine flow start to become complicated, disturbing the patient flow, then you can add on the 5-ARA. There are even some patients who have a very disturbed urine flow at the beginning. I wouldn't hesitate to start the combination therapy from the beginning, but of course, have discussed with the patient. So one thing that I always talk to patients is understand how they want to live. So I commonly tell them, especially young patient, this drug is good, but then if you ever use one, you have to realize that you may have problem with erection. So because of this, despite having problem with urination, there are still quite sizable number of patients, although they fit the category for combination, but they still rather opt for just monotherapy because they still very much enjoy their sexual life. So in that regard, so it looks like they have to stick on with just alpha blockers for the moment until coming to the point that they realize that they have to give up certain things in their life. Okay? Yeah, so this is quite pretty much the simple pathway for medical treatment for BPH. Of course, there are also the other pharmacotherapy, for example, the PD-5 inhibitor, the anti-muscarinic, or the Mebigon, right? So these are basically the anti-muscarinic for patients who have predominantly problem with the storage symptoms. So this may be helpful. But when it comes to pharmacotherapy, for example, supplements, so far there's no recommendations made from the guideline. So but I still respect patient's choice. If they want it, you could, but I still know that there's no obvious benefit from the literature. Okay. So next thing is prostatitis. How could we do for this prostatitis? Addressing this problem is better. So classically, when patient come with this problem of prostatitis, I have to preempt the patient. I let them know this is not something which is easy to treat. You are frustrated, so am I. Because why? If you look at the treatment for BPH, it's quite standardized, one or two choices. But when it comes to prostatitis, the choices are so many. So that means that none of which is actually working quite nicely. That's why there's so many choices. So patient frustrated, so are we. So patient, they must understand that it is something which is not easy to address, so that they understand why they are just not getting better. So the one before is simplest one. So this is the exact flow chart of how we could treat someone with a prostate. Look at it; it's just so complicated. Okay, so how do I do? So commonly, it is very, very normal for the patient to shop around for doctors with different bags of medication. Keep looking. So therefore, I just tell patient, as long as you can tell the patient that something that's not easy to treat, hopefully the patient don't having the trouble to keep going around for doctors, keep trying. they can just stick with one doctor. So at least it has established the trust and rapport. Then let us walk through the journey to see what we can do for the patient. Okay. So classically, the approach will be like, what could it be? As I said before, the infantry, sometimes maybe just avoid things that can irritate the bladder. For example, coffee and tea, dry ginger. Some patients, they describe to me, it feels like burns when they pass urine, when they take coffee. Some say they can't hold the urine. Some say they have to go to the toilet very frequently. So describe their story in different way, but fundamentally what they have is the same thing. Then the thing we can treat with pharmacotherapy, medication. So largely I follow 3A's principle. Antibiotics, for example, things like a quinolone group, anti-inflammatory, to address the inflammation, all right, and then the alpha blockers to address the constriction of the bladder neck. So hopefully with these, though, we can help the patient to pass urine, all right. Of course, though, since it could be a case of BPH on top of prostatitis, so we can potentially settle the prostatitis first and then continue the treatment for the BPH. All right. So in this regard, it looks like alpha blocker therapy is useful for us in many ways. Okay, not just BPH but also for prostatitis. But not all cases of BPH can be treated with medications. Eventually, the medication would just fail. So what are the complications of BPH? One, the patient could develop kidney failure when they couldn't pass urine. With the prolonged urine retention, patient could develop bladder stone and a urine tract infection. Of course, urine retention in this case, that means that the patient have acute urine retention, require the emergent insertion of a urethral catheter. Clearly, it's not comfortable. So these are basically the indications why we have to send someone for surgery. Classically, we go for TRP, but in years to come, there may be something new. All right. So, but at this point in time, TRP is still largely, we could say, like the gold standard. Okay. Yep. So I have quite a number of patients. They are basically need surgery, but given that I given a choice of medication, there are some patients that I was able to successfully avoid surgery. And with just 3 trials of medication, they are able to pass urine, even up to now, after 1 or 2 years. So I'm quite happy with the outcome, just simple treatment with medication and they can still pass urine. So what we could do when someone have problem with urine flow, urine retention. So this is one study that demonstrate how fusin could relieve someone with urine retention to pass urine. So it looks like, when a patient being treated with alfuzosin 10 milligram, the success to pass urine could be as high as 60%, which is good. All right. And then they could actually do it within a couple of days, I think 3 to 5 days. So it looks like this one, like a super drug, helping us the prostate part in so many ways. All right. Yeah. So therefore, I believe that patients who have problem with urine, give it a chance, let them have the trial of blockers, hopefully that they could pass urine, all right, avoid surgery, because surgery, as you know, can come with a load full of side effects, okay? Yeah. All right, so now we have spoken quite a bit about prostate. So is there anything else that might mimic what we see for someone who has problem with urine? Urgency, discomfort, frequency, nocturia. Is there anything that I've missed out? There's one more thing, okay? Not very common, but it happens. Someone have the compelling urge to pass urine, but more of pain, potentially more unilateral. The pain is short in duration, no fever. So maybe not infection, okay? So what could it be? What could it be? Diamond rocks. So a few cases, right, when the stone is in the very end of the ureter, at the vascular junction, so they might not have the classical loin pain, but they have the urge to pass urine. Suburban pain, then they say that more on one side. So case like this, without the classical appearance of a stone, but yet not really fulfilling a case of infection or BPH, think again, it might just be a stone. All right, so for this, you can consider doing a ultrasound or CT, so on and so forth, to determine what could it be. Stone, just as recent as last week, just one case. I thought it was a prostatitis, but it turned out to be a stone. Went for surgery. So if it is a stone, we need treatment, right? Treatment is classic operation, but do you always need surgery? If the kidney function is preserved, if there's no infection, and if the pain is not too bad, controllable, not really bothersome, then there may be a chance that we can actually monitor just yet, because the stone might just pass on its own. Okay, so in this sort of patient who is a case of stone, what else could we do? Drink lots of water, of course. Maybe a bit of pain relief. Hope the stone pass, and also you can actually consider use of alpha blockers. This is actually a strong rating in terms of the evidence from the European guideline, even as recent as 2019. Not all cases, but some patients who is pretty well tolerating the symptom, there may be a chance of using alpha blockers to relieve the pain. Yeah. So therefore, ladies and gentlemen, so once more, if it's suspicious, do not forget to go for ultrasound. But still, I have this one case, ultrasound shows nothing. Finally, persistent discomfort, went for CT scan, shows a stone. Quite small, but a little stone, but big trouble. Really painful. All right. I know, even though I have to say that alpha blockers, so on and so forth, but I personally haven't used this much, because most of the time when patients come in, there are lots of pain. All right. But there are some patients who come to clinic, all right, with the pain which is still tolerable. Yeah, we could try. Yeah. If it works, that's beautiful. But I just tell patient that when you come out, it's hard to say, it may be 1 week, it may be 1 month. Yeah. So therefore, you might need a serial close monitoring, and patient might understand they must come back, right? They should come back to make sure that the stone has passed. All right. Yeah. So, all right. So this is the last bit of what we're going to talk about, our urine tract symptoms. So, ladies and gentlemen, I hope my short talks on the LUTS give us a brief look at the prostate. All right. So hopefully what we learned today can be a bit of X-Men, be a good X-Men, and then do what it could for patient, so that they are gratified with what we can do for them. Okay, yeah, okay. Thanks so much for spending time again. We appreciate. Okay, thanks. Yeah.
Thank you very much, Dr. Goh, for your very amazing and informative talk. So here we have few questions that already in the Q&A session panel. So I will one by one, Doctor. So question number one.
Sure.
Other than alpha blockers, isoleucine, terazosin, and dual pharmacotherapy drugs, DODA, are there any new pharmacological therapy available or ongoing clinical trials or newly released to market to manage BPH?
Yeah, so classical is always the alpha blockers, or combination. The other thing that you can consider is the use of the PDE5 inhibitor, tadalafil, 5 mg daily dose. Yeah, so this is another emerging medication. So I usually don't use this medication unless the patient has both the problem with erection as well as BPH. Then it sounds more like logical, that one medication treating for both, because the medicine, this medication is actually not so, affordable for many patients. Of course, when it comes to the other choices, they are like, the antimuscarinic or the mirabegron. Yeah, these are mainly for patients who have more of urination, in which symptoms to be predominantly have urgency or frequency. Yeah, so still other choices, but depends on the patient's symptoms. Okay, yeah.
Thank you, Doctor. Next question. Patient on DODA complains of lack of ejaculation. Is it normal?
Lack of ejaculation? Well, I think patient on DODA, right?
Yes.
Yeah. So normal. very normal. So I give you one example. So if you say do that problem with ejaculation, I would say that it is mainly the result of the alpha blockers. Very normal. So therefore, must tell the patient that when they are taking the alpha blockers, whether combination or monotherapy, they need to realize that when they go for sexuality, they would notice a smaller amount of sperm pass. Why? Because some of the sperm have gone back to bladder. Is it harmful? The answer is no. Because when it passes urine, the urine will flush the sperm out. However, it can be problematic for patients who still want to have children. In that case, they may have problem to get a child in the future. So therefore, when I give this patient this medication, I will ask them, do they still have fertility ambition? If they have, then they must realize that it can be a problem for them in the near future. Okay? Yeah.
Okay. Noted. Thank you, doctor.
Yeah.
Is it compulsory to do ultrasound prostate before starting them with medication for newly diagnosed BPH?
Well, if you ask me, the answer is no. What we need to do is renal profile and UFME. Because if you go for ultrasound, basically you look for two things, right? Look for how big is the prostate. But yet the prostate size is not the only determinant of how good is the urine flow. And then you also want to see whether it's any hydrophysis. If the hydrophysis, it could mean that there is obstruction, but it is not always obstruction. So ultrasound might show this and that, but it is not a compulsory. I would say that renal profile is more important, because if the renal profile is deranged, that means that patient most likely may have an obstructed, then that means that they need more like a urgent treatment. Okay, yeah. So ultrasound to me is an option. Okay. Of course, the more we do, then we cut more things. For example, ultrasound. Like for myself, I go for a transrectal sound. I could pick up the calcification, saying that patient may have prostatitis. Then that might shift my direction of treatment a little bit different. Yeah. So the thing is that we can do, the more we do, then we can understand patient's condition much better. But not everybody has the facility of ultrasound. So therefore, you don't do it now. It's okay, but along the way, you can consider an ultrasound. Maybe not now, but maybe a month later, 6 weeks later. But what is the necessary at the baseline is the renal profile to detect any kidney impairment. Okay. Yeah. So along the line. Yeah. Okay.
Next question. In a 55-year-old male prostate, volume 40 grams, minimal symptoms, PSA 7.01, July 2020, 6.89 in June 2019. Normal GRA and TRUS, what will you suggest next? Any role of ciproflexation before redoing PSA measurement?
Yeah. So, can you tell me the age again? The age?
55 years old male prostate.
55.
Volume.
55. 55.
Doctor.
Yeah. 55, and then what? Yeah. What's the PSA? Yeah?
Prostate volume 40 grams, minimal symptom PSA 7.01, July 2020, 6.89 in June 2019.
2019. So the June 2019 and 2020, the PSA is about the same. Yeah. So for the 55-year-old man, having a PSA of 6 plus 7 is considered high. So this is one thing about PSA. So usually we say PSA, the cutoff value is 4. But actually the PSA value depends on patient age and also depends on patient ethnicity. All right. So let's say this man is 55 years old. The cutoff value for him, for a PSA, should be about 3.5. So 6 to 7 is already high. The good thing for this man is that over a period of 1 year, the PSA value almost the same, 6.8 to 7. So same. So therefore, risk of cancer is not that strong, because as we know, cancer almost always the PSA is just one direction, keep going up. 6.7 probably the same. So I'm not saying it is not, maybe not cancer. It may be a case of a prostatitis, because when the prostate is inflamed, clearly the PSA would rise also. So therefore, so in that case, there's a lot of things that we can consider. Depends on the patient, the risk of cancer. If he has a family history of prostate cancer, then of course, we got to look at more carefully. Maybe it's a case of cancer prostate, we have to do more thorough assessment. But in the absence of evidence on the digital rectal examination, on the ultrasound, and patient's not keen, then maybe it's a treat as a prostatitis first and then repeat the PSA sometime later on. Not too late, but maybe 1-2 months later on. Yeah, so there's still a lot of things we can do. Okay. Yeah.
Okay. The same doctor asking, any role of ciprofloxacin before redoing PSA measurement?
You could. Yeah, so the thing is, I would ask about the patient lifestyle first. If the patient is someone who cycle a lot, because the cycle itself can cause a high PSA. Let's say in the absence of reason why the PSA could go up, of course we can challenge with antibiotics for the patient, like using a quinolone. So one thing about using quinolone is that I will be quite careful with quinolone, because I always tell patients that quinolone works quite well for a case of prostatitis, but then the patient needs to remember that there may be a good chance patient can develop symptoms of joint pain, tendinitis, but to make it easy, joint pain, non-specific joint pain, fingers, toes, back pain, or new onset of pain. This can be a side effects of quinolone. So as long as they understand, because if you understand the reason, that's fine. Otherwise, though, they might just offer, okay, never mind, they want to observe first, so on and so forth. But in the case of, in absence of strong evidence of cancer prostate, I think giving a patient a drop of quinolone sounds logical and appropriate. Yeah.
Okay, thank you, doctor.
Yeah.
And how accurate are DRA and TRUS in reading out CA prostate?
I have to say that they are not that super accurate. Yeah, so the digital recognition is just a guide. Yep, but of course, where the tumor is very small, the fingers is not going to pick up anything. The transrectal sound, if it's loud and clear, we might just see a lesion which is dark. Yeah, but that also depends on how big a prostate. So little thing, it can be suggestive, but they are not that accurate. So therefore, we take things a pinch of salt. So they are not super accurate diagnostic tool. So it's just a guide. Yeah. Okay.
Okay. Thank you, doctor. Next question: what are the symptoms and treatment for prostatic stones?
Yeah. Prostate stones. I know. Actually, on the scans, whether it's a CT scan or ultrasound, it's so hard to say whether it's a calcification or stone. Maybe it's just a mix of both. So if the stone is there quietly, and then the patient has no symptoms, then we probably just leave it alone. But then if patient's symptom is very much like pain or not able to pass urine, and then after trying the medication, nothing seems to work, then that bits that we see on the scan, is a calcification, stroke, calculus, then I think a surgery to incise the prostate or evacuate the prostate stone may be useful. Or if I go for flexible cystoscopy, if I see that the stone in the prostate has been protruding into the through the mucosa into the urine passage, then I think there's a reason. Otherwise, I think the stone is protruding might just cause discomfort for the patient. Okay.
Okay, thank you, doctor.
Yeah.
The question is: doxorubicin more superior or better to treat patient with urine retention despite treated with alpozicin?
Do you mind the approval to repeat the question?
Yeah, sure, doctor. Is doxorubicin more superior or better to treat patient with urine retention despite treated with alpozicin?
Oh, I see. The thing is that when it comes to alpha blockers, right? I'm quite sure that different doctors have different preferences. Yeah, because if you ask me which is more superior, there's actually no clear answer. No, you can see the literature saying this and that, but one thing I do know is that in terms of their efficacy, they are about the same. The difference is the side effect profile. Yet, patient varies. There may be some drugs that say that they have no little side effect compared to the other, but when I use it on a real patient, some patient, they got side effects, so I got to switch the medicine to the class that's supposed to have more side effects. So I cannot say one is more superior than the other. Of course, no. I tell patients that so far there's no evidence say that one is more superior to another in terms of the efficacy. But if patient want to try, of course, why not? Because for all we know, patient is right. Yep. I hope I answered the question. Yeah.
Thank you, doctor.
Yeah.
Next question. If patients have normal urine flow but cannot empty bladder completely, and this only happens at night, is it BPH? And no complaints of other symptoms?
Yeah. So if the thing is that it is someone who feel their flow is normal, but actually pick up that the patient has incomplete voiding. That means retention. I think there must be a reason why there's urine retention, because normally everyone must be able to empty the bladder completely. So it is not possible to say that whether it's clearly it's abnormal, but what could it be? It can be so many things. Whether it's a patient diabetic, whether patient drink lots of water, so therefore there's a reproduction of urine. Yeah, so having retention urine clearly is not normal, but not all cases require treatment. If the urine retention is not much, let's say he voids about 200 or 300, he only retained about maybe 30, 40, 60. I think that's not too bad. Urine retention, which is probably we're talking about 100 or 200 cc, that is a lot. So if a patient retains small urine, I think it's probably best that just leave it alone, or I will educate patient to go for double voiding. That means after the void, or do not rush, just wait for a couple more seconds, then to void again. Double voiding, it allows the patient a chance to empty bladder as much as possible. Okay? Yeah.
Okay. Thank you, doctor. Okay. Next question. Any problem with alpha blockers in patients on anti-hypertensive medications with regards to postural hypotension?
Yeah, so far, I don't have anyone who have problem with the blood pressure control. Yeah, I know it's a very relevant question because patients who have BPH, fit and birth, and also fit and birth are those patients who are more likely to get hypertension. But reassuring so far, I haven't had anyone who have a drug-drug interaction causing a drop in blood pressure that much. Luckily, no. Yeah, I think because of the choice of medicine that I use. I use mainly alpha-zocin, so I don't see that much. Yeah. Okay.
Yeah, thank you, doctor. How do we manage patients who had tried on different alpha blockers but unfortunately experienced side effects such as bad nasal congestion and dizziness?
Yeah, so if the patient who truthfully cannot tolerate alpha blockers, again, we could switch class, because the difference in their efficacy is their side effect profile, but not efficacy. So we can switch drugs. So in a case that even switching drugs from the same class, that if they still have this problem of side effects, then I had to consider switching class. Switching class, the next one I'll consider is like using the PDE5 inhibitor, the tadalafil 5 mg low dose. Not many, but there's some who need this one because they just cannot tolerate alpha blockers.
Okay, thank you.
Yeah.
Next question, doctor. Prostatitis treatment, how long the antibiotic put on? Is it clinical diagnosis or need other tests to confirm it?
Yeah, so to treat the prostatitis, minimum duration of antibiotics is 2 weeks. It can up to 6 weeks. Yep. So therefore, I think it depends on how is the symptom control. All right. So if the symptom control has largely recovered, then 2 weeks it's just fine. But if the symptom control is still not improving, then recovering but not improving, then not improving entirely, then you can consider to extend the antibiotics. But if the symptom is not completely going away, you have to reconsider, is it truthfully bacterial or something else? So for someone who is elderly, diabetic, come to hospital frequently or stay in old folks home or use our urine catheter, think about fungal infection. It may not be bacterial, it may be fungal prostatitis. All right. Okay.
Okay. Thank you, doctor. Next question. For distal urethral stone, what upper limit for stone size for trial of expulsion therapy?
You mean for distal? Yeah. So the guideline says that for stone which is more than 5 mm. I think the reason is that any stone which is less than 5 mm, I think the upper purpose probably is not going to be useful because the stone is small enough. Whether you're going to pass or not, the drug is probably doesn't make much difference. So usually they consider the bigger stone. All right. This because stone about 3 mm, about 9%, it can pass spontaneously. If the stone is 4 mm, about 7% chance. If the stone is 5 mm, 50% chance. So I think that with the bigger size of stone, then more intervention required. If the stone is small, it's small enough, so the drug is probably not going to act anyway. Yeah, this is what I understand from the literature. Okay.
Okay. Another question. Can temper dose of 1 tab Zatral on to SAP COD if he has mild symptoms of BPH?
You mean taking the medication in the alternate day basis? Yeah. By right, the drugs only last for 24 hours, so it should be a daily medication. So I understand there are patients who consider taking every other day because one thing common because of the cost concern. Yes, I do have patients who take it every other day and they find they are quite okay. They understand the flow will be disturbed on the day without medication, but they could tolerate. So it's like a balanceable. They didn't spend too much, yet they could tolerate the flow on one day, but yet the flow is nice on the other day. So not indicated, but it come to the point that we come to the understanding that something that patient can tolerate. So I can accept that part.
Okay. All right. Okay. Next question. If elderly patients complain of frequent urination at night, no storage symptoms, no UTI symptoms, should proceed with rectal exam or should refer urology?
The thing is that when someone has problem to pass urine at night alone, not during the daytime, it looks like this problem is a monosymptomatic. That means that why it is at night but not daytime. So in that case, it's probably not downstairs, not bladder, not prostate, high up. So it can be a case of sleep apnea. All right. So it's quite many steps of explanation, but sleep apnea can cause a nocturnal polyuria, or it could be someone who has fluid retention. Let's say during the day, because of gravity, water retention around the legs. When they sleep, the water returns to the body, and that's why they pass urine at night. So therefore, come to the situation, I will ask patient, how good is their quality of sleep? They can sleep for 8 hours, but next day they still feel very sleepy, whether they snore. So this is suggestive of sleep apnea. Or I check the legs, whether there's any edema, leg swelling. So if that is very prominent, then it can be cause of leg swelling, causing a gravity change. So when they sleep at night, the fluids return to the body and they pass you at night. So therefore, this class of patients, the focus shift a little bit. Yeah. Okay.
Okay, thank you, doctor. Next question. Can 5-ARI be stopped if symptoms improve or it is lifelong once started?
Yeah, so the 5-ARI, there's a study, I cannot quite remember the study now, but for patients in which the symptoms is bothersome but not severe, moderate only, there's a good chance that you can use the medicine up to 6 to 12 months, and then you stop the 5-ARI. So there's a chance. But I do find it very challenging to stop the medication because somehow patients just let it continue. Yeah. You could try. Yeah.
Okay, thank you, doctor.
Okay.
And one more, last one, because time not permitted.
Sure.
Should I start BPH medicine if my prostate examination shows prostate not enlarged, but patient is having moderate score of IPSS?
Yeah. So the thing is, if the prostate is enlarged, but your IPS score is high, and then I think there's a reason to treat because as we know, the prostate size alone is not the only this. So the prostate size alone is not the determinant of how good is the urine flow. So if the symptom is bothersome and if the medication help with the urine flow, despite the process size, I think it is meaningful to continue with the medication. Okay. Yeah.
Okay. Thank you. Thank you, Doctor.
Yeah.
There's a lot of questions here.
Actually, sorry, back to the previous questions, right, about whether we can start the fire. I cannot quite remember. It's something which is quite, so, you can actually try, I don't have anything to back me up, but what I understand is that after 6 to 12 months, we can actually try to stop. But because I haven't practiced for a long time, because almost no patient will give up their good and effective medication. So therefore, I haven't practiced for a long time. Yeah. Okay. But theoretically, it could. Okay. Yeah.
Okay. Thank you, Doctor.
Yeah.
And thank you so much for all the doctors for the questions. Because time not permitted, I apologize for this one. And we will be ending the session now. And thank you for your kind attention. And also thank you very much for Dr. Goh for your all was wonderful talk. And we hope all the doctors can gain a lot of insight from this session. And also please tune us for tomorrow's session as well. And so you have a great day and goodbye for now. Thank you, Dr. Goh.
Okay.
Dr. Goh, do you have anything to say?
No. I mean, just thanks for spending the afternoon with us. Thank you. Okay.
Thank you so much, Dr. Goh. Thank you, everyone.
Okay. Thanks a lot.
Have a good day.
Thank you. Bye. Bye.